Welcome to this educational activity where Dr. David Wohl from the University of North Carolina and North Carolina AIDS Training and Education Center discusses effective communication tools to talk about risk behaviors and HIV prevention, how to identify patients who are candidates for PrEP, and methods to successfully adopt PrEP into clinical practice. The following audio is part of a certified educational activity titled Breaking Down the Barriers to PrEP, the Patient Journey from Misconceptions to Effective HIV Prevention. Access the entire activity and complete the post-test at www.peerreview.com/XKJ. Downloadable slides and practice aids are also available.
Why do people in the United States continue to get HIV infected? This is something I've wondered a long time about, along with many other really smart people. It's been 40 years since this virus was first detected in a human being. Recall, this is a virus that originated in some troop of chimpanzees in West Africa sometime in the last century. So there's been a chain of infections from those chimps to people in West Africa, then the United States, Europe, throughout the world. Wherever there's people, there's HIV. So why do people continue to get infected after all these decades? The CDC estimates that 40,000 people in our country acquire HIV each year. That's 80,000 people in 2 years, 120,000 in 3 years. By 5 years, 200,000 people get infected with HIV. That's the populations of Rochester, New York, Richmond, Virginia, Tacoma, Washington. 200,000 every 5 years. Do the numbers, 300 million or so people in the country, 1 in 300 people in the United States are HIV infected. So if you're like me, and think about this way too much, you look at NFL football or baseball game telecasted on TV and you see those stadiums full of people, 1 out of every 300 on average is living with HIV infection. Worldwide, 40 million people. So HIV is not over, not by a long shot. People continue to get infected. People continue to live with the virus, oftentimes not knowing that they're infected. Depending upon who you are, your risk for HIV changes. So not everyone is at equal risk. And there is huge disparities in who gets HIV infected worldwide, but especially here in the United States. But if you're a black man, your risk is incredibly higher than if you're a white man. And if you're a man who has sex with men now, and you're black, then you're looking at a 1 in 2 chance that you're going to get infected. So that means 50% of African American men who have sex with men can expect during their lifetime to become infected with HIV. For Latino men, it's 1 in 4. White men who have sex with men, 1 in 11. Huge disparities. Is that acceptable? More importantly, can we do anything about it? Sexually transmitted diseases have existed since sex has existed. Remember, sex is designed for the transfer of genetic information, right, from one individual to another individual, with the purposes of making a third individual. There is nothing more intimate than sex. There's no closeness between two people than sex, except for the product of sex, birth. And so germs hijack this process. They're opportunistic. So if there's going to be this intimacy, this sharing, germs go along for the ride. So whether it be syphilis or chlamydia or gonorrhea or HIV, they're transported along the way. And that's why we see these things continue. Right? We're not seeing decreases in chlamydia or gonorrhea or even really HIV. And it makes sense. STDs are hardwired. And we're hardwired to have sex. And we've got to do it. We've got drives to make this happen. Our brainstem is dedicated to this. But HIV is different in a couple of different ways. One, it's deadly. You could have a really bad case of chlamydia, but it's not going to kill you. HIV can. For none of these do we have vaccines. But what we do have for HIV that is very different is we have an intervention that could prevent virtually anyone from acquiring this virus and breaking this chain that started from that troop of monkeys decades ago in West Africa. So what if I told you that I had this intervention, highly effective, safe, very few people have any side effect to this at all, and that it doesn't involve a condom, and it doesn't involve anything that would reduce sexual pleasure, and again, makes you virtually bulletproof to HIV. Would you be interested? Would you want it? Would you at least want to learn more? Would you want your doctor to talk to you about it? Would you want it if you're a man who has sex with men? Would you want it if you're a man who has sex with men and you're African American and you have that 1 in 2 chance of getting HIV infected? Would you want it if you're an injection drug user and don't have access to clean needles because your government doesn't allow that to be provided to you? Would you want that if you're a woman whose boyfriend may be having other girlfriends and you can't trust him, even though you're monogamous yourself? Would you put your life on the line? Or would you rather take something that would protect you from HIV? Well, we have that something. That something exists. But unfortunately, only a fraction of the people who could benefit from it are receiving it. And that's not right. Tenofovir emtricitabine is a combination medicine, 2 medicines in one, that have been found to be highly effective at protecting people against HIV. It's not a vaccine. It's a pill. It's a medication. These 2 medications are used to treat HIV in combination with other medicines, but taken alone, protect people. 90 to 100% reduction in HIV acquisition if you take it the way you're supposed to take it. So highly effective, incredibly well tolerated, 1 pill a day. In real life studies, we find that, again, 90% of people could be protected. In one study in London that was done at sexually transmitted disease clinics, the best place, if you want to learn whether or not something's going to protect you from HIV, go to London, go to STD clinics, and enroll men who have sex with men. Okay, these guys come into these clinics dripping with STDs, and they randomize them to start on PrEP right now. Take it every day. Here's counseling. Use condoms. Please do what we need you to do. Or wait, we don't have enough information on PrEP. We don't have real-world information. Let's wait, find out if it works or not. The guys who got the PrEP, 86% reduction in HIV. There were 3 cases out of 269 men who got PrEP, compared to 19 cases in the 276 men who didn't get PrEP. The 3 men who got infected in the PrEP arm weren't taking their medicines the way that they should. These guys didn't all of a sudden become evangelical about condoms, believe me. STD rates were high in both arms. So risk behavior didn't change much. The thing that changed was acquisition of PrEP and no acquisition of the virus among men who got PrEP. Other studies have looked at this here in the United States. The Kaiser group in San Francisco had over 1,000 referrals for PrEP. And after assessing people, they found that maybe about 82% were good candidates for PrEP and wanted to take PrEP. That's 388 person years of follow-up. Among this cohort of men, almost 200 new sexually transmitted infections, but none were HIV. Real-world proof. This works. This is not being made up. Okay? This is not sugarcoating something. This really works and is so important. Because short of a vaccine, we need something that fills in that gap. Condoms are not the way that we're going to end the HIV epidemic. We learned that over the last 30, 40 years. Condoms won't do it. Condoms are not always available. Condoms break. People don't like condoms. Okay? That Millions of dollars of research has proved that. So we need something else. This is the something else. I told you 40,000 cases of HIV, new cases of HIV every year. Used to be 50,000. Since 2012, we've seen a deflection. That's exactly the year that PrEP became available. So there already may be an indication that PrEP is being effective on a big scale. Okay? But the problem is, not everyone, not nearly everyone who should be getting PrEP is getting it. The CDC indicates that maybe 1.2 million people in our country are candidates for PrEP. This is based upon risk assessment. Questions like, how many people do you have sex with? Do you use condoms or not? Could any of your partners be HIV infected? Are they known to be HIV infected? Do you have sexually transmitted disease history? 1.2 million. Okay. That includes over 620,000 heterosexuals and almost 500,000 men who have sex with men. Of that 1.2 million people who are candidates for PrEP in our country, about 100,000 are on PrEP. So even if you believe the CDC is overestimating how many people should be on PrEP, maybe it's 500,000, it's only 500,000. That still means there's a big gap between who should get PrEP and who is getting PrEP. What's more, if you look at the people who are getting PrEP, they don't look like the people who are getting HIV. And that's wrong. And so what we've seen since PrEP became available in 2012 is an upward march in the number of people who are taking PrEP. But it's still a fraction of those who could benefit from it. So currently we might have about 100,000 people on PrEP today. That's double what we had about 3 years ago. But it's still nowhere near the 1.2 million people. Even if you believe that the CDC is wrong and that maybe half of who they say should be on PrEP, 500,000 instead of 1 million or 1.2 million, we're still a long way away. So people who are getting PrEP, as you'd imagine, are people who have insurance, whose doctors know about PrEP. They live in urban areas like San Francisco, like New York, like Miami, like LA. They're white and they're overwhelmingly male. But that's not our infection. That's not our epidemic. Almost half of new infections with HIV are among people of color, predominantly African Americans, predominantly African American men who have sex with men. Maybe a quarter are white. More people living with HIV live in the South than they do in the Northeast or the Northwest or the West. That's not where we're seeing PrEP used. So we have PrEP getting out there, but it's not getting out necessarily to all the right people. It's important to make PrEP available for men in San Francisco and New York and Miami and LA, but we need to make sure it's available in Raleigh, North Carolina, in Birmingham, Alabama, in San Antonio, Texas. So why aren't we seeing PrEP used? What are the barriers to having PrEP available? Well, we could look at it almost like in economic terms. Supply side and demand side, right? There's always a supply and a demand. This is the balance. So the demand is on the patient side. Do patients want this? So the supply is us, the providers. So one reason we may not be supplying this intervention is we don't know about it. But more and more people do know about it. Dr. Oni Blackstock at Montefiore in the Bronx did a really nice study where she surveyed a national representation of providers and found 90% knew about PrEP. But when she asked them, did they prescribe PrEP, only a third did. Now, I can't believe 70% of these general practice providers have clinics that are made up of people who have absolutely no risk of HIV. So there's knowledge and then there's practice. Importantly, providers, I think, underappreciate their patients' risk for HIV and STDs. Okay? And we know, as I'll talk about in a second, patients underestimate their risk, and that compounds. There also may be among many providers a lack of willingness. Why not just use condoms, they'll say. On the demand side, again, complete lack of awareness about PrEP is a problem. So while providers know about it, their patients don't. There's an opportunity. When we ask providers, do you feel comfortable talking about PrEP to people like this? Talking about sexuality. Many people get trained, but there's discomfort. So now we have this perfect storm where people at risk for HIV don't appreciate their risk, and providers don't necessarily feel comfortable talking about sexuality, don't ask about sex, and so it goes unnoticed, swept under the rug, ignored. These are missed opportunities. These are clinic visits where something substantial could have happened, where that mismatch, that discrepancy, that horse and water just don't meet, and we've got to fix that. So how do we do that? Well, we got to do something that may not be as comfortable as we'd like, something that we're not trained usually to do, and something that for many providers is not part and parcel of their daily activity. And that's talk about sex. When we look at people and ask them about their risk behaviors, it's remarkable, the disconnect. In one study in Philadelphia, done at a really important big inner city clinic, using a standard assessment of risk given by trained assessors, men estimated their risk of being about 57%. But on the screening tool, 70% of them would qualify as having substantial risk. It was much worse for women. 8% of women self-identified as having risk for acquiring HIV, whereas the screening tool estimated 60% of them. This is a huge problem, because if you don't appreciate you're at risk, and your provider doesn't appreciate you're at risk, it goes unnoticed. Those are missed opportunities. Those are missed opportunities to prevent infection. And it doesn't take too many of those missed opportunities to perpetuate that chain and have more people become infected. And that's what an epidemic is all about. Sex is everywhere, right? We turn on the TV, it's there. Movies, there. We sell things with sex. So to really understand why we don't use PrEP as much as we could, and why we need to do more, and how we do that, we have to talk about sex. So sex is everywhere, but sex is not in the doctor's office. Sex is not in our clinics. And we need to start integrating that. Sexual health is part of general health. And if we don't appreciate that, if we don't teach that, we're going to continue to ignore sexual health at our own risk and at our patients' risk. So how do we talk to people about sex? It's remarkable that people think they know how to do this, but then when asked to do it or demonstrate it, they fumble. And that's natural. We understand that. So we have to become more comfortable making this a routine part of what we do. It's incumbent upon us, clinical providers, to ask people about their sexuality and do so in a way that doesn't make you feel uncomfortable and doesn't make your patient feel uncomfortable. And there are ways to do this and to be sensitive about it. And it's a little bit of an art, but isn't medicine supposed to be an art? We can do this. So if you want to know about it, you have to ask about it. Don't assume that if someone's not bringing up a sexual problem, that they don't have a sexual problem. Other studies have looked at people who come to just a general medicine clinic and ask them, do you wish your provider would talk to you more about sex? And overwhelmingly, people who respond to these surveys say yes, that I wish my provider would talk to me more about it. And when you talk to providers, of course, they say, I feel uncomfortable talking to some of my patients about sex. So again, another disconnect that we have to bridge. You don't have to be perfect at doing this. You're going to fumble along the way. There's things you're going to try that fall flat with that particular patient that work with another patient. It's okay. But make it routine. And there's some techniques that I use, that others have used, that I've learned, even after I thought I knew how to do this, and after getting trained to do it better, have appreciated that there's better ways to do things. And we should always develop and innovate. And we could do this as well with sexual history taking. So sex is normal. Sex is healthy. We shouldn't assume our older patients don't have sex. There is national survey data that show that as long as people are fairly healthy and active, they continue to have sex well into their 70s and 80s and beyond. So make no assumptions. It's easy to check in. And make it routine. So the way that I think about this and that others have taught me to think about it are the 5 Ps. We talk about partners, we talk about practices, we talk about past history of STIs, talk about protection from STDs, and lastly, pregnancy plans for those who could get pregnant. So I ask my patients routinely about their sexual health and try to get our clinic as a whole to think about this and do positive messaging around these 5 Ps. So for partners, it's very easy. Tell me about your love life. Horrible question, but it opens up the door. Love life can mean lots of things to different people. You can say it a different way. I ask about sexual health to all my patients. Tell me about the sexual relationships you have. Tell me about intimacy. However you want to couch it, to open up the door and then get more specific. Have you had any kind of sex with anybody since I last saw you? Pretty general, pretty open. Okay? Your patients get used to asking these questions. If it's an initial encounter or you don't know about your person's sexuality, don't make an assumption. Do you have sex with men, women, both? Again, I ask this of everyone. People will tell you. How many partners have you had since I last saw you? Really important. Are you in a relationship with anyone? Are you intimate with anyone? Opens up the door for more questions. Is this someone you're emotionally connected to? Or is it more of a friends with benefit? What about your partner? Because you may say, well, do you have any sex with anyone? Do you have a partner? Yes, I have one partner. Do they have sex with anyone else? Sometimes. Or I hope not. These are questions that get answers that can open up doors again for you to explore. What about practices? Okay, you said you're having sex. You have 2 partners in the last 3 months. What kind of sex are you having? Okay. You say you're a man and you have sex with men. Okay. What kind of sex? Oral sex, anal sex? Tell me more about that because I need to know for your health and to think about sexual transmitted diseases. Try to avoid judgments like, do you have regular sex? What does regular sex mean? Doesn't mean anything. For oral sex, are you a giver, a receiver? We're talking about anal sex, we talk about top and bottom. Again, these are terms we have to get familiar with because they help us understand. In my mind, I'm thinking, where do I take the swab and swab if I'm going to be looking for a sexually transmitted disease? Okay, so this gets into the mechanics of what we have to do as a doctor. If you're concerned about your patient and their sexual practices, or if there's concerns that they bring up about number of partners, about risk behavior, you might want to ask more about drugs and alcohol and having sex under the influence. We also ask about past STDs, because past STDs are a good predictor for future STDs. Okay? So which ones? And that may help you understand more about that person's risk behavior. I have one partner now, we're monogamous, but 3 months ago I had chlamydia. 6 months ago, I had gonorrhea. Okay, that opens up the door to discuss more about your partners and your other risk behaviors. What do you do to protect yourself against STDs? This is really important because a person can have multiple partners. I've had patients come in, they're men, they find other men on apps, but they are strict about condoms. They never have sex without a condom, and even oral sex. And so that tells me something very different than someone who comes in and says, well, I use condoms maybe half the time or most of the time. So STDs and how you protect yourself from STDs is really important to this conversation about your risk for HIV and about the use of PrEP. Pregnancy plans are also important. There are women who want to get pregnant, so they don't use condoms, but they're not clear about their partner's risk of HIV or their HIV status. So that's an important thing to think about as well, and again, may indicate who's appropriate for PrEP or not. So candid questions, easy questions that can be integrated pretty quickly and efficiently in your clinical practice. Tell me about your current sex life, tell me about your love life, who do you have sex with, men, women, both. Again, pretty well integrated, they can flow. Importantly, even if everything's good, I think it's important to open up the door for them to ask you questions. Do you have any concerns about your sexual health? Is there anything we should talk about as far as sex? If not, go on. So when you're doing this, in your mind, you're thinking, okay, I need to find out if there's any problems about this person's sexual health, and I need to protect them from the things I could protect them for, treat them for the things I should treat them for. So what about PrEP? Well, who's a candidate for PrEP? And it's not that complicated. The CDC has a wonderful list listing people who are most obvious to maybe a little bit less obvious to you. So someone who's HIV negative, who has an HIV positive partner, a known HIV positive partner, no brainer. But for me, it gets down to this. If you're a person and you have genitals, and you use those genitals with another person who has genitals, and that person could be HIV infected, you should be on PrEP. It's as simple as that. If you can acquire HIV from another person, if it's possible, you have candidacy for PrEP, and you should be considered for PrEP. Let's say you decide that that's the right thing. I counsel my patient and say, I think this is right for you. About 3 weeks ago, I had a woman come in who accompanied one of my patients, an HIV positive patient, to clinic. After which she said, can I talk to you alone? I said, yes. So she talked to me and she said, I'm negative. I've known your patient for 30 years, and I've always had a thing for him. We went to high school together, and I support him. I bring him to his clinic appointments, and I wouldn't say that we're partners, but we're definitely friends with benefits. What's my risk of acquiring HIV? And I happen to know her partner sometimes doesn't take his medicines for complicated reasons. It has to do with insurance and has to do sometimes with his depression. So she's at risk. So she says to me, am I a candidate for PrEP? I saw that there was literature in your office. I never heard about that before, but now I know there's a pill. Should I take that pill, and will it work for me? And it will. So we tested her, sent her blood to the lab. We're able to make sure she was not infected. She had no symptoms of acute HIV infection. We checked her blood to also make sure she had good kidney function, because we need a creatinine clearance of 60 or above to use tenofovir, which is included in PrEP. We also checked her for hepatitis B, because chronic hepatitis B infection is important to know about if you're going to start someone on PrEP. Hepatitis B is caught very many same ways as HIV is, so there's an overlap, and it's an incredibly catchy virus. Millions of more people are infected with hepatitis B than HIV. It's not a preclusion. You can use PrEP in people who are hepatitis B chronically infected, but you should realize that the PrEP that we're using is extremely effective at treating hepatitis B. So it's a 2-for-1. So if somebody comes in and gets treated with PrEP and they're hepatitis B infected, really now you're doing two things. You're protecting them from HIV, but you're also treating their hepatitis B. And if you're treating their hepatitis B, you don't want to stop treating their hepatitis B, even if they decide, I'm going to be celibate, I'm going to join a monastery, and I'm never going to touch another person again. You still want them to stay on PrEP or tenofovir and emtricitabine, now because you're treating their hepatitis B. And if you stop that hepatitis B therapy, their hepatitis B can roar up and cause problems. Other than that, that's pretty simple. It's pretty easy. You establish the candidacy, some baseline laboratories, most importantly, making sure the person's not already infected with HIV, make sure their kidneys are doing great, and check their hepatitis B status. So how often do we do this? What I do is I'll prescribe PrEP, counsel people, encourage them to use condoms, but understand that condom use is not going to be absolute, and that's why we're giving them PrEP. I want to see them back in a month, make sure that everything's going okay. I give them a month supply, no refill. I want them to come back. I want to test them for HIV. Because what we don't want to have happen is someone take the PrEP, engage in risk behavior, stop taking their PrEP, continue to engage in risk behavior, acquire HIV, and then start back on the medicine, which again is insufficient to control their virus. So I'll check for HIV every single time I see them. At a month, I can assess for side effects, adherence patterns. Then every 3 months after that, I can assess them. Each time doing an HIV test, each time assessing for sexual transmitted diseases and the risk for those, and swabbing, getting blood as I need to. Renal function, not a big deal, maybe twice a year. This is incredibly safe. The other thing that I like to do, and I think is really important, is just because someone starts on PrEP doesn't mean they need to take PrEP forever. In fact, they probably won't. We assess seasons of risk, we call it. Are you still at risk? Is this something you still need? My patient who I saw, whose friends with benefit partner came in, if she came back and said, you know, I've had it with him. He drives me crazy. Found somebody else. He's HIV negative. I'm not going to see this patient anymore. Her season of risk ended, and she no longer has to be on PrEP. So I think it's important to determine, because people change. The other thing we have to do, of course, is check them for other STDs. If someone's coming in and telling me that they're a candidate for PrEP, or I assess them and understand that they're a good candidate for PrEP, there is travelers, co-travelers that can come along, right? Chlamydia, gonorrhea, syphilis. And so what we want to do is make sure we test them for those things. So blood tests for syphilis could be done on the same blood draw that you've done for these other purposes. And we want to take out those swabs. So when I'm asking the questions about how do you have sex, where do you have sex, are you a top, are you a bottom, you use condoms all the time? What about for oral sex? Nobody uses condoms for oral sex. Okay, let's get out the swab. And where do we swab? We swab the throat. Okay. We swab the bottom. We get urine for gonorrhea and chlamydia testing. So syphilis testing from blood, gonorrhea, chlamydia testing from urine and from swabs. Okay. It's really interesting. If we just rely upon urine alone, which is so easy to get, we miss a lion's share of gonorrhea and chlamydia. Studies have shown us that you can increase dramatically the retrieval rate for both of these STDs if we look at extragenital sites, okay, at the bottom and the mouth. More and more people are giving people kits to take into the bathroom and get self-collected swabs. Some data from Seattle say that the retrieval rate of chlamydia and gonorrhea actually go up when people swab themselves rather than we swab them, even for throat swabs, which is pretty remarkable. So what's it going to take to end the epidemic? What's it going to take to get us from 40,000 to 30,000 to 20,000 to 10,000 to almost nobody getting infected? It's going to take us thinking hard about how we identify people who are infected, get them on medicine, keep them on medicine, and make sure that they can't infect other people because their virus is just so negligible in their body. But on the other side, we need to get people who are at risk for acquiring HIV and make sure they're protected. Short of a vaccine, one pill a day that would protect you from HIV is a great way to render this virus moot. And this gets to be not just a discussion of a medicine and an indication. This gets to be something more. When we see that, again, disproportionately, people of color, men who have sex with men, people living in poverty, the uninsured, those are the people acquiring HIV. And if we think about, well, who could benefit from PrEP and who is currently benefiting from PrEP, this becomes not just a medical issue, it becomes a social justice issue. And I think for all of us, it's a matter of equality, a matter of good medicine, and a matter for us to take seriously and be obligated to rectify. Because that's what we're supposed to do. To just ignore it and allow these discrepancies, allow these gaps to continue is just unacceptable. So each one of us has to think about it, whether we're an obstetrician, a gynecologist, a pediatrician seeing adolescents, family practice, or internal medicine. We have to integrate this. We are seeing people at risk for HIV, and either we ignore it willfully or we're ignoring it because we don't know better, and that's no longer acceptable. Because now you know. You've listened to me. You've heard me speak today. You know the data. You know how to do this. It's not that hard. We just have to make it happen and make that practice. So I challenge each and every one of you to think about people you're seeing in your clinic. Think about who might be a candidate for PrEP. Learn how to use PrEP. Keep people on PrEP and prevent those HIV infections. Thank you for your attention.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerreview.com/XKJ. This activity is supported by an educational grant from Gilead Sciences, Incorporated. This activity has been jointly provided by Medical Learning Institute, Incorporated and PVI, Peer Review Institute for Medical Education.